Alex is tremendous. He's got such energy.
All right, folks, looks like we're live once again. That's probably the last time you're going to hear me say that for a while, because, folks, this is our final session of our 6th annual Overdose Awareness Series, and it has been such an honor being a part of all of these sessions. Now, I'm not going to keep you too long because I want to get to the stars of our session today, but that, final reminders that the way you're connected to the session through Whova, we want to hear questions, we want to hear comments, but we won't actually be able to hear them because you are all muted. So please add those comments and questions into the various chat boxes you see or the Q&A box through both Whova as well as the Zoom embedded stream within Whova. And another reminder for folks who are interested in those certificates of attendance, please keep an eye out for a end of series email we'll be sending pretty soon. That's going to have a lot of information in it. We'll link to some of the past recordings, and we'll continue updating the website with those past recordings. And we'll also have a survey you can fill out. One of those questions will be about those certificates. Now, again, like I said, I'm not going to keep you too long, but I will introduce the CEO of the Washington Poison Center, Dr. Scott Phillips, who's going to lead this session and introduce our speaker. Dr. Phillips, it's all yours.
Thanks, Alex, and thanks, Justin. This is a bit of a different session. We're doing a kind of a sit-down, fireside kind of chat. And today we're really going to focus on resource-limited practice environments. And that's been a topic and a theme for this whole session. And I thought there'd be nothing better than to discuss issues of rural hospitals and local health jurisdictions and EMS, who are all facing a perfect storm of limited access and financial instabilities, workforce shortages, et cetera. And so I asked a friend and respected colleague of mine, Dr. Sam Artzis, who's here with me. Thank you for being here. I appreciate it. So Dr. Artzis is the local health officer for the Tri-County Health Department here in Northeast Washington. He's an emergency physician, family medicine doc, long career, whole career in rural medicine, really, I think. Yeah. And just provide exceptional care. And I think you're going to learn a lot from our discussion today with Dr. Artzis. So I would like to say that, we're going to start really by looking at, I think, these 3 areas, hospitals, health districts, and EMS. And let's take hospitals first. And we're going to focus a little bit on Ferry County Memorial Hospital in Republic, which is one of the critical access hospitals in the state. It's one that Dr. Artzis works at as well. And, it's been around, I think, about 80 years. But geographically, it's quite interesting. It's the only hospital within about a 40-mile radius, the only hospital in the county of Ferry County. And it's also critical access hospitals, but the hospitals that are the next sphere out, the next drive out from that hospital are also critical access hospitals. So you have to go some distance to get to a more tertiary care center. But why don't you just tell me about the services kind of that is available at Ferry County for the people there? I know it's a health district, so it's funded by tax dollars, which is keeping it going so far.
So far. It's basically we have 8 beds for our acute care side, 5 beds in the ER, fairly dated hospital. We have very limited resources, but during COVID, we expanded those resources to include ventilators, high flow oxygen, and we do quite a bit of trauma there and a lot of complex internal medicine cases because these are patients that are elderly, don't have access to primary care. And so we deal with a lot of very complex cases in our ER. The challenge with the hospital is that we have one highway in and one highway out, and they're 2-lane highways, both over mountain passes. So probably 9 months out of the year, we don't have air transport, and we'll get into the emergency response system too. But during the wintertime, we pretty much end up having to take care of patients, if not for hours, for days, both because of where we're at, not being able to get ambulances or air transport in. And then the next problem is our regional medical centers are full, which you guys probably have heard about more than once. So we have to wait for beds, and we've sent them anywhere from the west side of the state down to Idaho and also to Montana. We have a wide variety of places we end up sending people for
Wow.
bed availability, and that becomes a huge challenge.
Wow.
And so we face some different challenges than the west side. And Scott was alluding to it earlier. People just don't understand, and I think I've had this conversation frequently in other meetings, and I don't think they actually believe it.
Yeah. And to give you a little perspective, it's, you know, Ferry County Hospital, Memorial Hospital is about a 2.5 hour drive to Spokane, kind
On
of
a
the
good day.
nearest big center in good weather.
Yeah.
And that's over Sherman Pass, which is, I think, the highest all-weather pass in the state, over 5,500 feet. And it can be difficult and challenging in the winter, to say the least,
Yes.
and the source of a lot of trauma for you guys as well. So, you know, it is certainly remote, I think. And when we're talking about limited access areas and limited resource areas, I think Ferry County really depicts that in a big way. But now I understand that there's some renovation plans for the hospital there.
Yeah, we're looking at adding a new acute care and a new emergency room to our facility. But ran into some changes in our administration and some financial challenges, so it's been delayed some, but we're still planning on building that hopefully within the next few years.
So that will allow you to keep more people, or to do more outpatients, or both.
I think it would be it's hard to say. Anytime you build a new facility, there's an expectation you can increase your volume and you can increase your services. But as you know, even over in Colville, which is a bigger facility, it's hard to get those people to show up,
Yeah.
to work. And
Yeah.
so our goal is just to make our facility have more room, number one. Number two, a better outpatient surgical facility. We do a lot of endoscopy there. And right now we share our ER and our ACU beds to do the PACU, the post-operative care. And that becomes a real challenge when we have a busy hospital going, plus trying to do that. So we're trying to get some more room to continue the procedures and the services that we have.
Yeah.
I don't know, because we only have one doctor on staff, and I'm going to just go back a little bit. We have a doctor, basically have a nurse, we have a radiology tech, and we have a lab person. That's who provides all the services. We don't have ancillary care. We don't have IV therapy. We don't have respiratory therapy. We don't have anesthesia. And so to increase our services and add the numbers would be a huge tax unless we were able to hire more doctors and more staff, which in this day and age, I don't think is going to happen.
Yeah.
So,
And that's at any one time period, one physician. And
yes, we
nurse.
only have one doc. And the challenge we have is we don't have backup docs. Most of them live, one's in Canada, one's in San Diego, and then two of us are in Colville. So to get somebody to come over and help with an OB patient or trauma becomes a real challenge too. So.
Yeah. So sounds like trauma, and I would think trauma, OB, and maybe sick pediatric cases are some of the most challenging cases.
They're the ones that get our heart rates going. Yes.
Yeah. Yeah. And I know it's hard, and it's really hard with monitoring equipment with critical patients. And I know when I was working at Mount Carmel and Colville, that Sam would call me up and send patients, and I was always happy to accept them, understanding the limitations that we were both under. But it's challenging, and when a critical access hospital serves as a referral center, that also becomes an issue, just because the tertiary centers were full. And of course, COVID was the big challenge that really put everybody out there. So have you heard any whispers about the whole Medicare funding issue in Ferry County? I know it's a hospital district, so it might be a little preserved from that, but
Yes, I mean, we've heard the same thing everybody else has, that, the funding is going to be cut, and nobody really knows. Our CEO, who's worked in many different rural areas, feels like it's just talk, and that they're going to have to come up with a solution, because if they just start closing critical access hospitals across the country, we're going to be in deep,
Yeah.
what. And so he feels like it's not going to be as bad as what we think. And so we're trying to stay positive about that right
Yeah.
now, but nobody really knows. We're all speculating.
Right. I know. And I know there's been lists of, I think, 11 hospitals that have gone out, critical access hospitals.
Interestingly, they listed some hospitals and didn't even notify them.
Yeah.
OMAC was one of them. They were told they were on that list, and they're going, they're making money and they're doing fine. And they go, why would we be on that list?
Yeah.
And so I think that list was arbitrary.
Yeah. And it also shows the communication that's going on, not helping support the resources.
No, it's creating a lot of anxiety.
Yeah, it's really creating a lot of that. So, the other thing is with smaller hospitals, that small patient volumes are kind of economies of scale. So you don't have large volumes of outpatients or, profitable procedures. And so, particularly in these kind of counties, a lot of people have a fixed amount of Medicare billing, Medicare, Medicaid billing coming in, but the private insurance funding is much more limited in rural hospitals in Northeast Washington, Central Washington, all over Washington with the critical access. So that's an issue. And so I'm sure having the hospital district is going to be a bit of a buffer for that, which is good news. Yeah. How about the aging workforce? Did you find your workforce is aging there, or aging out, or renewing?
We were lucky. We do have my age and older. I'm probably one of the oldest providers probably in the region right now. But
since I retired.
And so we got lucky. We had some nurses come out of school and start training with us, their first jobs.
Wow.
So probably 4 or 5 years ago, we had some challenges as far as ability level, but these were very good nurses. They live in the community. They have families there. And so they've been very invested. And so they've increased their skills, whether it's ACU, ER. And so we have a good core group, and we've been very fortunate. I was just telling you, we've had some Canadian nurses come down that have been very good. So our level of care has been maintained, if not gotten better. So I think we're fortunate, because a lot of people work in hospitals and they get traveling nurses. That can be a real challenge because they don't know the system. They don't know where anything's at. They have a different set of expectations. There's a thing what I call regional medicine. They come from other places. Everybody does medicine different.
Yes.
The East Coast to the West Coast can be a lot different. And so getting them into the groove of our regional medicine can be a challenge. And so there's a time lapse there where you have and then they're usually gone by the time they learn the system. And so we've been very fortunate with that.
Yeah. So that you don't have any overnight staffing limitations, or is it?
It can be. I mean, we sometimes have to limit what we can admit to the hospital if we don't have enough staffing, and that's a challenge off and on. It's usually related to illness or those types of things.
Unpredictable.
Well, COVID's been probably our biggest challenge. We'll have 5 and 6 staff people out at a time, and that can be a real challenge.
Yeah.
So, but that's not been too consistent recently.
So one of the services that has been sort of instigated in a while, and the Poison Center is part of that, is really telecommunications or teleservices. And, before, a few years ago, it was much more robust, I think, with tertiary centers and getting feedback. And it seems like there's less support nowadays. Would you agree with that?
Yeah, we're getting better as far as our primary care is doing some teleservices. Our problem is we only have about 40% connection in our county. So I mean, for them to do teleservices, they just don't have internet service to be able to do that. So they either have to come to the clinic and do their teleservices with the regional center. And our challenge too is also people wanting to access that.
Yeah,
a lot of people don't want to.
They don't want access to it.
Yeah.
And how about for you in the hospital, like getting help from tertiary centers?
About the only thing, as you know, would be neurology. They had the, the robot that you could use. We don't have that anymore. It just didn't work out. And our connectivity at our hospital can be very poor as well. And so it's just what we haven't been able to consistently get that done. And then with our consultants now, there's a concern about their responsibility being listed on the chart for giving advice when they haven't seen the patient. And that's probably almost all specialties other than neurology and cardiology will not talk to us unless we are actually transferring the patient physically to them. They will not even talk to us. So
Yeah. Do you have telepsych services available?
it is available through UW. We
Yeah.
can do that. We have a psychologist on our staff that can do some care.
Oh, good.
But they're overwhelmed.
Yeah, I imagine. There's
They're-
probably one of maybe the only psychologist in the county.
Yeah. Well, we've got new alliances over in
Oh, okay.
in Republic as well, but they can only do Medicaid patients. So if they're
Oh,
not
okay.
Medicaid, they don't see them.
Yeah.
So
Yeah. Wow. Wow. And that sort of brings up what we kind of talked about before, this disparity gap that exists, with kind of the levels of illness that can occur, critical illness in a remote area versus the level of care that's available, which is really limited by resources and equipment, other staff, other specialists. And that is always going to be a problem because you'll never be able to staff up for that.
well, we can't afford it, and we don't have enough business. Like for a respiratory therapist during COVID would have been amazing for us.
Yeah.
But we couldn't find one, and now that we can, we don't have enough volume for them to be able
To need one. Yeah.
stay busy. And
Yeah.
so,
And no surgeon in the county.
nope.
So no OB other than family
All that.
medicine OB doing it. So,
Us.
so all that's an issue. Yeah. Well, let's kind of phase into, we'll kind of talk about transfers. What kind of options do you have for transferring patients
Well,
when there are bed available outside? How do you go about that?
Spokane's our main tertiary or regional medical center, Deaconess Multicare in Providence, Sacred Heart, Holy Family. We got the Valley we can, send to. We use Tri-Cities. Confluence and Wenatchee is usually very, very few times have we been successful getting transfers over there just because they're busy as well. So our real options for things that don't require neurosurgery or, super subspecialties, we go to other critical care hospitals. And it used to be Mount Carmel, but because of the challenges you guys have with surgery and those things, we haven't been using them as much. We've been sending patients over to OMAC, which is another critical access hospital for general surgery. But it's a real challenge. I mean, in bed availability, when you say better, it is a little better, but it really depends on the day. I mean,
Yeah.
we can go 3 and 4 days with no beds anywhere,
Yeah.
locally. And then sometimes we can get
Yeah.
somebody out within 30 minutes,
Yeah.
but typically that's not the case.
Huh. And so what do you do with a crashing patient and no beds?
We take care of them.
Yeah. Yeah.
And we do actually, I say that and make it sound like, oh my goodness, but we actually do very good work. And the
Do
nurses
very good work.
And it's funny because we could have everybody from the custodial care to maintenance to our unit coordinator to our long-term care staff come in and will actually everybody pitches in. It's
Everybody
pretty amazing to
pitches in.
watch
Yeah.
when we have trouble. We'll call EMS back in and have them help as well if we need
Oh,
extra
that's
hands.
fantastic.
Yeah, so
Yeah, that's really
it's a
fantastic.
very good community as far as wanting to help. And so
That's good.
we can get things done. It's just not
Yeah.
pretty. It's really not pretty.
Huh. Well, as a segue with EMS coming in, let's kind of switch over to EMS. What kind of training of EMS staff do you have in the county? And
Well, we have EMTs, so
Uh-huh.
not paramedics. We have some that are IB trained, but basic EMTs is basically all we have. We just don't have enough money, number one, and number two, volume to support a paramedic. We've talked about it. We have paramedics in the county, but have protocols they can use, but we can't consistently keep them busy enough for us or our EMS to make money at that. And they cost a lot,
yeah,
as we can talk about here in Stevens County,
yeah,
the challenges they're having.
Right.
So really,
right.
a lot of the times docs jump on board, and right now we're trying to get our nurses. There's some liability issues with sticking a nurse on an ambulance, but we're getting them
Yeah.
EMT trained so that they can actually do the transports rather than have the doctor get on board and have another doctor have to come over and cover while you're gone.
Yeah.
So, but not infrequently do we have to jump on the ambulance and go with them.
Wow. So what do you think is kind of a average length of out and return ambulance ride, and what's the longest?
Well, if it's EMS, it's going to usually, and that's the challenge too. People don't understand we have 2 ambulances, in Ferry County that can be staffed. And so if you have one ambulance leave the county to go do a transfer, that leaves us really vulnerable for any immediate calls, 911 calls. And so we try to really limit how often we send an ambulance out of service. So typically 10 hours. I mean, realistically, get them down, get the patient into the room, do your paperwork, get back on the ambulance, grab something to drink on the way back. By the time you get back, it's usually 8 to 10 hours.
And what's kind of the longest response time you think for EMS?
Oh, hour and a half. And a lot of times, this is going to sound
That's
funny,
a one way or a round
just
trip?
to go get the patient.
So it's a 3-hour round trip.
Well, to get the patient, get him back to the hospital can be 3
And
hours.
is that with good weather, or is that with bad weather?
Well, bad weather, a lot of times the ambulance has to stop and we have to get either a snowmobile or an ATV to go up and retrieve the patient, bring them back down to the ambulance, and then get them back to where we're at. And the second challenge is, this is going to sound funny, we don't have an updated address system. And so when they get sent out on a call, they can't find where the patients are at. And so we just got a grant to actually put address signs up for people so we can actually find them, because a lot of our time is trying to actually find the patient, because they don't know where they're at and we don't know where they are either.
I didn't know that.
Yeah. So we just got $100,000 grant, I think, to go put
Get signs.
addresses up on the road so we can find them.
Wow. Wow. I'm sure they have the situation where somebody in a pickup truck drives them to follow the pickup truck to the
Many
location.
funny stories of how we get patients out. And then we have no communication either. A lot of times it's a dead zone.
Yeah.
So our ham operators actually will help us communicate
that's good.
to keep in touch with like trauma scenes or CPR or those types of things.
And how's the funding for the EMS system?
Not good.
Is it also part of the hospital district or county, or
is county
fee for service?
Well, fee for service in Stevens County, and we're seeing how that's going. I mean, they're I don't think they can survive, and to try to make it a tax-based system, they don't think they can get the voters to approve it, which is mind-blowing to me that people just don't understand that the ambulance isn't going to show up someday.
Yeah. And it can have similar response times.
Exactly.
Of 3 hours, maybe more road signs. Doesn't do any good. And any trouble with EMT training or anything?
We're at this moment, we're doing okay with our volunteerism, but and it's not just here, across the state. If you have volunteer services, they're very hard to keep staffed.
Yeah.
So we're doing okay at the moment, but that's always a challenge.
Yeah. Turnover or just trying to get new people?
Well, a lot of people come in and do their EMT, and then they want to get their paramedic, and so they have to go to Yakima or Spokane or some bigger area to go get those trainings. And so we will lose some to paramedics. Some of them these are people that have 9 to 5 jobs or 8 to 5 jobs.
Right.
They have families, and so the time commitment too can become daunting, and so they have to take time off.
As I recall, back in the day, it was one of the local auto body shops also ran the ambulance system.
Yeah, it was a station wagon.
Station wagon,
an old station wagon.
Back in the day,
It was called the Shack.
The Shack, yeah. Wow. So as far as the EMS system there, what do they need? More staff, money?
Both. And then the other challenge we have is Stevens County does not respond to us ALS. And so we have to rely on Ponderay Fire District 2, which is 2 hours from our facility, to get an advanced life support team to come over. And so really it's time.
Yeah.
There are some services available, but they're so far away, it becomes, sometimes a moot point. We got to do something before they can get there. And so really time, money, and staffing.
So Dr. Artzis is also familiar with, obviously, with Stevens and Ponderay counties, because that in his area as the local public health officer. You mentioned the ambulance system in Stevens County. What's going on with that?
Well, I was their MPD from 1998 until the beginning of 2025, and it's always been finances. You know, you can't run a hospital. The reimbursement for ambulance services is terrible on a good day. You know, you're making pennies on the dollar for a call, and the average call is $900 to $1,000 just to get out, pick the patient up, and take them back, and then the bill on top of the services you provide en route. They don't get repaid for that. And so fee for service, if we bill Medicaid, Medicare, that's not going to be good. Private insurance, I think, is better, but so it's just an issue of how their business model is set up. Fire districts do much better because they have a tax-based system. They have more money,
Yeah.
usually more resources. But Stevens County has struggled ever since I've been, was the MPD, and they still haven't figured out how to make that work. And so they're looking at, honestly, I think they're looking at probably Ponderay is going to come over and provide ALS services if they can't survive financially. So, which is not a good thing.
Yeah, I know there was an article in the Spokane paper last week or the week before about that very issue that everybody is struggling. So,
and it's all the way. Stevens County is a huge county. It's probably one of the biggest counties in the state. And so when we talk about, we're talking very much Colville centric, but Fire District 1, which is down on the south end of the county, is having the same challenges. Deer Park closed their ALS service, I think. And so we're really limited on our responses, and the response times in a county that big can be, again, an hour and a half to get a patient.
Yeah.
So the golden hour is usually not even feasible.
Yeah. And what is it about Ponderay County that makes them have paramedics that seem to be doing okay?
Well, the north part of the county, where I was talking about Fire District 2, which is up in the northern part of Ponderay County, they were a fire district and they were able to hire several paramedics, but then they couldn't make money because interfacility transports are where you make your money, not 911 calls. And so they started bleeding over into our county and filling in where we couldn't, if we didn't have enough paramedics. And so they've been able to keep themselves going with these interfacility transports plus their 911 calls, and they're going through their own challenges right now. They lost Newport, and so they're trying to figure out how they're going to continue to function. And so they're kind of at an impasse with the commissioners trying to do a tax-based system. The south part of the county is not agreeable. North part of the county is, and so they're trying to figure themselves out as well.
Wow. Okay. So it's not just Stevens, it's really impacting everybody.
If you talk to anything other than a major, and even AMR, which is a huge ambulance service, during COVID, I would call their CEO frequently to try to see if we could get a car parked up closer and those things, and they were struggling financially, and they have been too. It's not, I won't say it's not lucrative, but it's really hard to survive. Even the big companies are having trouble surviving.
It's slim on that. Yeah. Wow.
I don't think we lobby well enough.
It kind of makes me, come to the third area is really the health departments serving the area. And I mean, all this has to impact, it's got to flow backwards and impact them and flow forwards and impact the hospitals. And what's all that in a relationship and difficulties, and how's the health department holding up with all of this?
Well, at the beginning of COVID, this is always the joke. We started with 6 people for 3 counties, basically myself, our administrator, community health, and then even our environmental health was involved with our response for COVID. And we're still functioning with about the same number. We have a few new people we added during COVID with the COVID money, but that's going to go away. And so we have very limited resources. We do quite a bit of emergency management as well, for wildfires and air quality and infectious disease and those things. And so we're definitely intertwined with both the hospitals as well as other partners in the community. And it's a real challenge because we're asked to do a lot with no money and no people. And that's not changing. It's going to get worse again. And the funny thing is we're used to it. So we just go, here we go again.
And it seems like on the state level that everything is getting tighter as well.
Well, that budget deficit we had, public health had to eat part of that too. And so we are very fiscally conservative or frugal, and so we always plan on not having money. And so we've been one of the few districts that have been able to, I think, do fairly well with very little, just because we don't spend a lot of money. But our county contributions have gone to 0 now, which is going to be a huge challenge for us, along with
And how about MOUD in the Tri-County area? How's
Um,
that evolve with the whole fentanyl?
Well, I think the nice thing is Providence with Dr. Caleb Holzer, who's got the hub and spoke program, that's actually carried us. We've got limited providers out in these smaller communities that will do some of that. Our fentanyl and other substances. It's never just fentanyl. It's usually
Right.
fentanyl, meth, heroin.
Yeah.
It's usually a mixture of things. It's a real challenge, and we're
Yeah.
seeing overdoses frequently. And
Right. Not to mention alcohol and tobacco
well,
and
yeah, all
the
that too.
daily double. Yeah.
But fortunately, we've got the Providence has taken that with UW, the hub and spoke, and so that's helped a bunch. And Kayla has been very proactive and very helpful. And
Yeah.
so we're better off than most, I would think. I don't know, but
Yeah.
so we do have some resources there.
Yeah. That's good. And so I know there was one patient I heard about needing methadone, but they had to drive to Deer Park to meet the van or something,
Yeah.
and they couldn't get a ride to get there every day. And so you see that as kind of a limitation to drive, what, 80 miles round trip from Colville to Deer Park
Well,
to get your methadone.
before buprenorphine or those things, we had people driving daily to Spokane because methadone clinics are a specialty and it's a government program basically, and there's a lot of requirements for that. And for us just to open a methadone clinic up in Colville would be near impossible. And so it was very common back in the day that people drove down for their methadone every day.
Yeah.
And I can't tell you how many accidents we had with people going down and getting their methadone and
Yeah.
not making it back.
Yeah.
So
I know there's has been debate on this, whether people on methadone maintenance actually have more accidents on maintenance than others. And there's some studies that suggest in the first 90 days when you're ramping up, you have more, but it seems like the relative risk is about 2 of methadone maintenance versus non-maintenance.
well,
So I
anecdotally, I
can
would
see
agree
that.
with
And you
that.
put these people on the highway, it's
Well, and 395 is the most dangerous highway in the state right now.
Yeah.
I mean, so that's our highway between Colville and Spokane, and it's a terrible highway, especially in the wintertime. And the joke is I survived 395 so far, and we've had 6 fatalities in the month of July, not just on 395, but 2 are on 395, and that's not uncommon. So,
yeah, 6 in July.
yeah.
Wow, that's something. Yeah, and that seems to be, part of this whole issue of the drivers of the problems of, we'll just call it healthcare, all these different areas. The geography is one, obviously, the terrain, the transport, the weather is always an issue. The economics of it, the poverty, underinsured, aging populations,
And access. A lot of them can't
and
even get to the
access.
hospital or the
Yeah.
clinic. I mean, that's the other challenge. That's why they're so sick when they show up, is they didn't have
Yeah.
any way to get there.
So is it mobility or transportation or both?
Financial, transportation, and not understanding the medical system. It's amazing.
Yeah.
You
Yeah.
wouldn't think that people wouldn't understand they can dial 911 and come see us, or they're just very resistant. It's a fiercely independent community up
Yeah.
here, and they don't want.
Yeah.
They do
Yeah.
not want to see a doctor if they don't have.
Yeah. And I will tell you that both Dr. Artzis and I have driven patients home from the hospital. We might be the only two. I don't know if anybody else has done that, but it's a
Or just go
different,
see them at home. That's probably half my practice.
Yeah,
Is going
keep-
to see them at home.
keeping it home. Yeah. Yeah. So the infrastructure, the hospital in Colville is pretty good. Newport still has, some aging structures there and overcrowding. It's a zoo in their waiting room. But it sounds like, there's at least plans for some additions, developments at Ferry County, which is going to be great.
We'll see.
Any policy gaps, you think?
How so?
Payment models, licensure barriers, underinvestment, rural workforce training, any kind of policy things?
You know what? And this is going to sound funny, but housing.
Yeah.
We can't
No,
get
it's
people to
social determinants
Yeah,
of
I mean,
health. It's the basic.
You
Yeah.
can talk about policy all you want, but if they show up and they have to live in a little, it looks like a little annex schoolhouse, that,
Yeah.
that's where we house our hired help.
Yeah.
And it takes months to over a year for them to find a place to live. And so housing
Yeah.
right now is the biggest challenge we
Wow.
have to get people to come and stay.
Yeah. And that's just for employees, let alone
Correct.
patients.
Correct.
Yeah. And it's hard to discharge people that have nowhere to go.
Exactly.
Certainly it is emotionally anyway. It's hard to discharge them to nowhere.
To the house that
Uh,
has no electricity,
You
no
know,
running
when
water,
we're
no heat.
almost obligated to have a safe discharge plan and there's no such thing, oftentimes is kind of
You know, Republic is very good about that. The community really comes together to try to make sure people can at least get temporary, whether it's with a friend or a do-gooder or somebody, to at least get them someplace. And we have much more lax discharge policies. I shouldn't be saying this, but than Colville. You know, you guys got to get them in. Medicare's not going to pay. We got to get them out. We just, for whatever reason, we're able to actually keep patients longer, either house them in the ER or put them in an observation or inpatient, keep them and then swing them. We can do that. And
Yeah.
so we have a little better discharge planning than most, I think.
Yeah. Yeah. There's a lot of pressure to move
Yeah.
people out for sure. So, you know, we talked a lot about the limitations, and you put a lot of blood, sweat, and tears in the Tri-County area and in your career. What's gone right? What is
The
going
people,
right?
the people, I mean, and no offense to the west side, west of the Cascades, but people are, even our psych patients that are, you know, we call crazy, they know they have issues. They're very sincere. They don't have false expectations. They're not litigious. They're not going to sue you at every turn. They're very appreciative of the care they get, very appreciative of the aftercare they get, like you go taking them home or going to see them at home. And the communities here are fairly tight knit, and so they take care of each other. That's what's kept me here, honestly. I mean, I wouldn't go to an urban area to work just because of the people, and the people that work in hospitals are there for the right reasons, I think.
Yeah. Yeah. I think that's true of all the smaller hospitals.
Yeah.
The camaraderie and the workforce. So,
And getting things done. There
yeah.
are no committees. If you
Yes.
need to get something done, you make a phone call and they say, well, if we can make it happen, we make it happen. You don't have to go to a committee, a subcommittee, and then go to Providence's board, you know, and wait for
Yeah.
6 months for a minimal policy
Right.
change.
Right.
We can get things done.
Yeah.
And so it's very nice.
Yeah. And I think the other thing is, in a smaller community, you know, if the roads are terrible, you can call the county highway people and they'll clear the roads for you.
Yeah.
For the ambulance to get out. And so there is that, or someone with a snow machine will go
Yeah.
out and, you know, help extricate a patient from,
Search and rescue loves to get called.
do they?
Oh yeah.
Well, that's good. So that's one
It's
of the
fun
things
for
that's gone
them,
right.
so.
That's one of the things
And
gone right.
autonomy too.
Yeah.
You know, there's not a lot of bureaucratic administrative interference with your practice. You can actually do medicine and do it with some latitude, you know, as long as it's good medicine. But
Yeah.
we still enjoy kind of the old days of medicine where you don't have the C-suite down in the ER with you breathing down your neck. And
Yeah. Yeah.
part of the reason I left corporate medicine. So.
Yes, I understand that. I understand that. Well, thank you. Dr. Arch, you've been very generous with your time, and I really appreciate that. Any closing thoughts you have, or?
I appreciate you having me. It seems like rural areas, we always feel like we're left out, you know.
Yeah.
So this has been an avenue for me for whatever audience we have today. Hopefully it's an audience that maybe in an urban center that doesn't understand,
Yeah.
or other rural LHJs that can share my pain.
Yeah.
But at least be able to sit down and talk about this.
Yeah.
We're usually preaching to the choir, you know, sitting in a public health
Right.
meeting where all the chairs are turned inward, nobody outside's really hearing us. We need to try to get the message
Right.
out.
Talking to ourselves.
Yes, exactly.
Yeah.
So this is a good way to do that.
Yeah. And, you know, and I will say that, you know, the idea of having this sit down conversation with Dr. Artzis isn't a new topic for the two of us. We talk about this not infrequently. Probably every time we talk, we kind of think about some of the limitations that you're facing and what could change, what could be better, what's going right. And so
Scott's my psychologist. So.
We call it talk psychiatry.
What was it called? Valent sessions when you're a resident.
Yeah. Oh, well, again, thank you very much. I
You're
appreciate that. And Alex, I'm going to send it back over to you.
All right, perfect. Thank you both. That was just excellent. I think what a great format for the final session of this year's series. I'm admittedly very jealous of your setting right now, being like outside with the nice weather as I'm in a windowless office. So I think this was just, in terms of vibes as well, just an excellent, excellent
And
setting.
don't tell anybody where we live, and don't tell them we exist over here, because we don't want any more people.
I know, yeah, no Seattle transplants
Yeah.
showing up.
Too
Fair.
late.
Very
Scott's
fair.
here.
Now I'm actually not seeing any questions in the chat box. So folks, as I'm asking a couple that I've put together along with Justin here, please use that time to ask any questions, share any final thoughts you have. Justin came up with I think a really nice one. A lot of the conversation you both focused on was response time limitations, and with those limitations in mind, do you at all see more like community or public focused like CPR trainings, first aid trainings, and naloxone trainings to try to spread out equip other folks to respond to situations as they can?
We're actively doing that. There's a leave behind program we use through EMS, public health. We actually have kiosks up where you can go get COVID testing, STD testing, Narcan out of these, like a candy dispenser. You can get them from
Right.
there. We've done quite a bit of public awareness trying to get Narcan out. We're trying to encourage our PCPs, our primary care docs, for anybody who's taking narcotics to also have Narcan in their homes. And so that's been very successful. The CPR training, the thing you need to remember, if you're not in Walmart and go down and there's an AED that you can actually shock somebody out of whatever catastrophic rhythm they're in, if they're 20 minutes out or 30 minutes out, the chance you're going to do successful CPR, have the ambulance show up, be able to get ROSC or return of circulation and get them back to the hospital and have them survive. I don't know what Scott's success rate is. Mine's about 2 in 30 years when they're out of the hospital any distance. And so, yes, we can teach CPR. It's a good thing, but just by the limitations of our response times, the outcomes are usually very poor. I hate to say that, but that's the truth.
I think that is the reality.
Yeah.
It's not, we're not dealing with Medic One in Seattle
No,
with a
there's
4-minute
no
response time, and a lot of people trained. We're dealing with an hour and a half one-way response
and no
time
meds. Our
and no
EMTs can't
meds.
give any meds until they hit the hospital. And so by then the writing's on the wall.
Yeah.
More than 9 times out of probably 99% of the time.
Yeah. And I think that the population in a lot of the rural areas are accepting of that, though they're willing to trade off access to high-level medical care to live in an environment that they want to live in. So
They're very realistic about their outcomes. Even in the hospital, they're
Yep.
awake and can talk to us and tell us their wishes. A lot of them do not want to go to Spokane. A lot of them want to either stay comfortable,
Yeah.
let us try to fix them there, and where the chips fall, that's where they fall. They're happy. The families are happy just because they're fiercely independent. Like I said, they do not rely on medical care for their well-being, and they've gotten to where they're at just by true grit and support from families. And the central family still exists up here, where they got grandparents living with kids and living with the grandkids. And so, and death is not a crisis for them.
Yeah.
Whereas
not
the
to be
rest of
feared.
us are vivis, we want to live until we at the very last second can't live. These guys are very accepting of death. And so that makes our job easier as well.
Yeah, thank you for elaborating on that. And I think what you were saying about CPR is very illuminating, because what we see in Hollywood and movies and stuff is like it shows this high efficacy of CPR, and it doesn't frame it as like the Hail Mary that it really is. So I appreciate you walking through that. Just a comment on my end, not a question, but something that I really like hearing from you a few different times throughout the discussion. You've highlighted both the independence and the community, how strong the community ties are there. And I think that's great. I think a lot of folks could fall into that false assumption that if you're independent, you're not community oriented. And I love that you've elevated both in this discussion here. All right, I'm going to refresh that again. I've got another. Oh, I am seeing a question here. Do you have a recommendation on how much naloxone an individual should have on hand to respond to an overdose based on how far from a hospital they are?
Go ahead, Scott.
Well,
usually they've had about 10 doses when they get to the hospital.
Yeah. Yeah,
All the 9 bystanders have their own dose, and they're just
yeah. When you're in the throes of it, you feel like you never have enough. Um, Honestly, if you use one box or 2 boxes of, so 4 nasal things, it's likely something else is involved as well. A sedative of some type or alcohol or something else that doesn't respond to naloxone. And so that's where you can't keep spraying their nose. You got to start to give them a little mouth to mouth ventilation, or with a mask if you have a mask to use as well. So that's why really CPR courses are being, naloxone is being integrated into basic CPR, because that's really where it belongs for people that are having respiratory arrest. So I would say a couple boxes. I usually carry 2 to 4 boxes with me in my vehicles or trauma kit that I've had to
Thank you.
use.
There was a follow-up to that same question. Also, do you know how much naloxone the local ambulance will carry?
we carry plenty.
Yeah, I would imagine it's quite a bit.
Well, and it's partly because we have the leave behind program. So they'll have, if you, and this is going to sound terrible, if you have one addict that's down, they're usually with 5 or 6 other addicts. And so we need to distribute, because they've used all their naloxone on that one patient who's down. So we need to replenish them. So we usually have plenty. If that, I wasn't trying to be facetious, but that's kind of how it works.
Yeah, awesome. Thank you. Yeah, I think you answered the question. Well, thank you very much for that. As folks are thinking of any final ones, earlier on in the conversation, I honed in on you both talking about some regional differences. You can see whether it's, someone coming from a different country or even West Coast to East Coast, just in how medicine can be practiced. Do you have just any off the top of your head examples of some of those differences you've come across that may have taken you aback?
Well, Dr. Cal Rattray, who trained over here in Rural Training Track, same program I went through, went back east, and he and I would talk frequently when he was on shift, and everything from antibiotic usage to interventions to testing. I mean, it's across the board how they approach things, and even in the state we do things differently. And that's driven by 2 things. One, the training of the doctor and how good they are at what they do, and then 2, what resources are available. I can tell you that I'm not going to do a lumbar puncture on somebody and be able to get cell count differential and all these different uh, cool PCR things we do to look for infections, just because I don't have it available. And a send out is not going to be clinically helpful to me, because it's going to take 2 to 3 days to get back. I got to make a decision. So my algorithm of care is going to be different than somebody sitting in a tertiary care center. So it's amazing to me. I didn't realize how different it was until one of my colleagues actually went over and practiced on the east side of the country and just said, you would not believe how much different it is. And they may not do as much. They have a lot less aggressive care in some places, and then we tend to overdo, in other places. And so it really just depends on staffing as well as what your resources are.
Right,
Is
right.
that,
And
you
No.
know better than I do.
Yeah, I mean, I trained in the East Coast too, and I would say, lived in Denver for 20 plus years, and it's very geographic. Practice of medicine is very geographic, and it's like you said, it's all depends where you trained and what medicines you use. Just for nausea, what medicine do you use in your community for nausea? What were you trained to use for nausea? Some of that is sort of evened out, I think, over time, but there's still big differences on a lot of practice things, antibiotic choice or whatever it might be. So
Well, and their disease processes on the East Coast, infectious disease especially, may be way different, even in tick-borne illnesses,
right.
parasite illnesses, and those things are different. I wouldn't know what to order over here. And you look at somebody doing screening on the east side of the Mississippi, they have a much better knowledge of those things than I do. So if you don't know what you're looking for, you're not going to find it. You can't know to order it. And so, like I said, your training makes a huge difference in the type of medicine you do.
well, thank you. Thank you for walking through that. All right, I'm going to do one final refresh, but I think we'll go ahead and wrap up this portion. Yep, I'm not seeing any additional comments or questions. Folks, if you think of those after the fact, feel free to post those. We'll do our best to follow up as we can. But Dr. Artzis, Dr. Phillips, this was wonderful. This was just such an excellent final session. Now, I'm not going to talk for too much longer before I pass it back to Dr. Phillips for closing remarks, but I do want to give just huge thanks to the folks who've been attending these sessions, whether you attended just today, whether you attended every day, or some of the previous sessions earlier in the month. A reminder, we'll get all of those posted up on our website, up on YouTube as well, so you can access any recordings of any sessions you missed or revisit any recordings of sessions where you want to clarify a data point or anything like that. I also want to quickly thank this year's sponsors and partners. This is the first year we've ever tried opening things up to sponsorship. So big thank you to We Work for Health Washington, the Washington State Department of Health, specifically their drug user health program, as well as their teen health hub. And then, of course, the Washington State Healthcare Authority and their Friends for Life campaign. Final reminder, if you want those certificates of attendance, keep an eye out for the survey we'll send out. Dr. Phillips, that is it for me. So I will pass it back to you for any closing remarks for this year's series.
Great. Well, thank you, Alex. And so we have come to the end of the 2025 Overdose Awareness Series, the 6th series that we've done. And it's really want to extend my gratitude to all the participants, the presenters, the advocates, families, community members, and partners, different organizations who've really joined us. We've talked a lot about different conversations, heartfelt, shared stories, some with loss, some with hope, some with both. Talked about some innovative solutions to honestly one of the more pressing public health crisis of our time that we're living through right now, with overdose, suicide. Fentanyl is a big component of that. But we like to think of this series as really more than just an event. And we really need to think that, behind every statistic that we talk about is a person, a child, a sibling, a friend, a neighbor, and that life matters. And that's why we do the things we do with counseling, with naloxone, with direct patient care. And we've tried to remember those that have lost and those that are struggling and trying to stand together. And, your willingness to be a participant in the audience and join us is really what brings meaning to the work for me, and I think for Sam as well. So throughout this series, we've heard from a lot of leading experts on overdose risks and suicide prevention, some of the complexities by synthetic opioids, and the lecture prior to this one was on nitazines from Marlo from our center, one of our clinical managers, stimulants, emerging substances. We had a great discussion on psilocybin as a therapeutic agent, was very, very illuminating. But, we also talk about the sense of community, and I think that really came through in this talk as well. Our community of other organizations, and I like to think that we're not just lecturing to each other, that we're really fostering a way to get the information to the outside, to the public, to the community, to those who can really benefit from this. We have talked about some of the unsung heroes, the first responders, healthcare providers, counselors, community volunteers. There's just so many. There's clergy involved. All these people are really dedicated and, changing lives daily. And I want to thank them for that. And I think we want to celebrate the progress. Washington State has made significant strides in expanding access to naloxone, increasing availability of treatment services, not just MOUD, but other psychiatric services. Good support from the state on harm reduction programs, which has been very beneficial, and a lot of community-based innovative approaches like Dr. Artz's Leave Behind Narcan program. And a lot of communities are doing that, but that's a good example. Even in a remote area, it works and it's important. So I want to make sure that we don't lose momentum, just because it's the end of the lecture series. I want to make sure we keep thinking about the ongoing challenges. Overdose deaths, they're still all too frequent. The challenges are complex. There's always going to be substance use and misuse. There's always going to be toxicologic challenges that we face with. But we have to think about some of the lessons we've learned. We've heard Dr. Leonard talk about gas station highs and the substances you can pick up at gas stations, which was very interesting. Dr. Pappy, one of our certified poison specialists, talked about social media, and Mike McCormick talked about the legacy media and how to interface with that and to get your messages out. I had mentioned Dr. Temple's talk on psilocybin has its positive impact, particularly on post-traumatic stressors and some depressive symptoms. And that's really a fascinating whole area that is something to look forward to in the future, that we may have something that may actually change how people can function for a long period of time, not just be medicated and seem to be in the same rut. And we also had Dr. Davies and Mallory Little talk about fentanyl and methamphetamine residue questions earlier today. So I think whether you're a healthcare provider, a policymaker, an educator, a parent, someone with lived experience, you have a role to play, and every conversation matters. And the Poison Center in Washington, we want to be engaged. We really enjoy having conversations and forging these partnerships, and working in outreach is really vital and important part of our mission at the Poison Center. So as we fade away from this conference, I encourage you to consider, how you can contribute to safer and more compassionate Washington. I think that seems to be a lot of what we're dealing with, is loss of compassion on multiple levels. So share what share what you've learned. Knowledge is a force multiplier. It can carry on. Carry naloxone. Endorse harm reduction and treatment and recovery services, and advocate for access, I think are really important. And I think on a special note, I want to offer special thanks to Secretary Worsham for his insight and leadership, and others at Department of Health, and for the Secretary's really enlightening keynote address on the first day of this session was really fantastic. A special mention really is to our outstanding educators at the Washington Poison Center, Alex, Justin, and Megan, who've done a great job developing, organizing, recruiting, and facilitating this process for the 6th year. And there's also people behind the scenes that have done a lot of meaningful work to keep this series going and to keep it upright and monitoring it. So I want to thank Michelle and Ana Maria and Sierra and the Poison Center leadership team for really making this a masterclass in education and outreach, and I want to thank them. So as we conclude, we want to remember that awareness is just the beginning. From awareness grows understanding. From understanding grows action, and from action, we foster more hope. So I'm renewed, and I hope you are as well, in our commitment and our purpose, and I'm hopeful of what we can achieve together. And with that, I want to thank everyone for attending, and thank Dr. Artzis for joining me today. And we hope to see you next year. Thank you. Alex?
Thank you so much, Dr. Phillips, Dr. Artzis. That was a perfect way to wrap up. So folks, keep the dialogue going. Reach out to the Poison Center at any time, and we hope to see you all soon. Take care, everybody. Stay safe. Bye.